Awesome. Thank you so much, Jeremy. That was wonderful. I'm going to go ahead and ask you our first question and then see if any of your co-panelists want to weigh in on that. And I want to take us back to a session from earlier today where Christina Rudd shared some data in her presentation on sepsis epidemiology that illustrated pretty stark differences and disparities in sepsis incidence and outcomes by geographic, and particularly linked to underserved areas and underserved populations. And I think it's not too far of a leap to think that may likely extend into areas of diagnostic quality as well, beyond incidence and outcomes. And using the levers that you describe here for policy level interventions, how can system level efforts help address and at least rather than reinforce existing inequalities within the healthcare system?
Yeah, I think I'd go a step forward, and not only is it not too far a leap, but I think the data suggests that particularly at the state level, these mandates for sepsis performance improvement have widened healthcare disparities. I think that there's pretty strong data. And it's understandable because everything that I just described, both the federal policies and the state policies, are very resource intensive, right? And it costs money. I often say, quality costs money. Costs and quality are endogenous, and to think that we can improve quality and reduce costs is a bit of a myth. And when we ask hospitals, particularly underserved hospitals, to invest in quality improvement, it's a real stretch. So I don't have the solution, but I will comment that I think would be inappropriate here is to use only one of the levers that I use at a time. We really have to take a holistic approach, specifically thinking about investment in information technology, right? And we've already done that. There's precedence for that under the concept of meaningful use and the HITECH Act to say, as we develop these machine learning tools, and as we develop the ability within an EHR to rapidly and fastly diagnose sepsis and provide contextual feedback to clinicians, how are we going to make sure that under-resourced hospitals that lack sufficient funds can afford that? And there's only one way, and that's by investing in them. And if we do one of those without the other, we will widen those disparities, period. And we really need to take that holistic, more broad-based approach.
Hallie, what are your thoughts on that?
Yeah, no, I think this is a super important point. As Jeremy referenced, that there has been evidence, like in health affairs, that as the New York State regulations rolled out, that there was improvement across the board, but the amount of improvement differed across hospitals, and that in general, higher resourced hospitals were able to improve more, where lower resource hospitals that disproportionately take care of minority patients had more trouble improving, such that you have, widening disparities over the course of such an initiative. So this is something that we have thought a lot about in my Quality Improvement Collaborative. And I think one of the keys there is that Blue Cross Blue Shield actually provides the resources to each of the hospitals. So they pay for the data abstraction. They also pay FTEs for quality improvement. We survey the member hospitals every year and ask them about, would you be able to participate in this without the resources? And the vast majority of hospitals say, no, this is only possible for me to sort of fully participate because I'm given the resources to do that. Like Jeremy says, quality comes with cost. The other thing I'll say is that we also want to be sensitive to the fact that there's sort of variable performance across hospitals, and we want to set up our incentives such that every hospital is sort of equally able to improve. So, if you just set a threshold and say, oh, you've got to get down to 30% on this, otherwise you're not going to get the performance support, and the hospital is nowhere close, what is their incentive to really engage there, right? So we really think carefully to make sure that we're sort of looking at both absolute but also relative thresholds so that every hospital is sort of equally incentivized, and it's a reach, but it's not impossible for them to improve over time, year to year. And so that's something that gets, looked at every year, and we sort of tweak things again, sort of always making it a reach or a stretch, but feasible for hospitals to meet the marks.
Vinny, are there lessons from the Kaiser Permanente system that can be applied to this?
Yeah, I absolutely echo, the message is quality is costly. But if financial incentives are aligned correctly, those costs can be cost shifted. from, impending harm due to, poor processes and structures that are in place to something that I think it can be preventative. But, I think Christina's talk about disparities and the lack of kind of facilities really to do some of that preventative care, and that's where we see the greatest impact, I think, really heightens the fact that we need structural change and realignment of how we apply those costs in order to really, execute on the value equation. The other thing I'll comment on, and kind of what's become a little bit of a North Star as someone who works deeply within a healthcare system, is the Institute of Medicine's Learning Healthcare System Framework, which is an image in which there's patients, families, and communities at the center, and then surrounded by technology infrastructure, and then surrounded by incentives, culture. I can't remember the third one, but this is a socio-technical, and patient and clinician system. And health IT won't be the only lever, because we've seen deployments that are massively expensive and complicated that don't produce the kinds of rewards that we hoped for. And so there's, we really have to get those incentives aligned and then leverage the best of the innovative technologies that are coming available to improve our care.
That's great. And Vinny, I'd like to actually follow up a little bit on where you were going with that, because I'd like to take us back to Helen Haskell asking for us throughout this conference to consider what the patients and the families' roles could be, how to prepare them more to engage. So at the level of, actual, what can a patient do? You were talking about primary prevention, primary care, specialty care, that time before going to the emergency room. Is there something that you've seen in action at Kaiser, or ideas you have about how to engage that team member, the patient and the family member, more effectively?
Yeah, I mean, I think we've done a lot in terms of education of patients and their families, and I mean the community as a whole. And I particularly want to call out patient advocacy groups, including Sepsis Alliance, the Staunton Foundation, and others that have really pushed for patients to understand what is sepsis and what are the worrisome signs of sepsis. Because patients are, and their families are a bit of an underutilized resource here. Again, they're a little bit of a risk stratification system. They know that when your mother or grandmother has a fever and then develops some confusion, that patient needs to be evaluated. But I think a lot of our communities still don't understand that. So we still have work to do in education in order to try to get ahead of the more deleterious effects of, worsening inflammation and organ dysfunction, and figuring out how we partner together. Now, clearly having access points into the system. So if you recognize those symptoms, that there's a low barrier of entry to whatever that, whether that's the emergency room or an outpatient visit or a virtual care visit. We need to do a better job at making sure that we can get those access points that they work for patients and providers, again, to prevent those downstream consequences.
Great. Very interesting. Thank you. Hallie, do you have something to add based on your work in Michigan or other experiences?
Yeah, in terms of how to sort of better leverage and engage families in this. Yeah, I mean, I think that one of the things that I've often been struck by talking to patients, but also talking to just my own family members who are non-medical and their sort of lens on the healthcare, is that I think they often think of things as very sort of clear cut, like there's this diagnosis, we make it, we know it with certainty, and that sort of errors come from like us not treating appropriately. But I think this sort of the murkiness of medicine and how often this diagnosis is uncertain, I think is often lost on a lot of patients. And so sometimes you'll have conversations where you'll say, okay, this is what they're doing. And the family will say, oh, but, previously it was something totally different. And so then I think this distrust evolves because there was never a recognition that in the beginning, yes, we diagnosed it, but actually that was our sort of best understanding at the time, but it wasn't complete. And as more additional information comes on and we sort of can follow the patient's trajectory, that our sort of understanding of what's happening may evolve. And so we don't sort of lay that groundwork up front that, this is kind of our current best understanding, but it's incomplete and it may change. I feel like we sort of sometimes breed this distrust down the road when our understanding of the situation changes. So I think sort of just explaining uncertainty, like conveying that to clinicians, but conveying that to patients is really important, and sort of understanding the complexities that we're dealing with. The one thing that I found to be hugely important in my practice is that we now routinely invite families to rounds in the ICU. And as they see us struggling with all of this different data, they actually build this trust. They see how hard we're working and that we're sort of thinking about one thing, but there's also this. And they sort of understand that we are really doing everything we can to understand and best treat the situation. So I think that really helps. And, as we've had to, for a while, keep a lot of people out of the hospital during the pandemic, that became even more clear, I think, just how important having families present and integrating them into our workflow to sort of building trust. Because when you have that conversation over the phone, it's just much harder for them to kind of understand that we're doing everything to sort of best understand and treat their family members. So those are kind of my thoughts on the topic.
Thank you.
Thank you. We're just about out of time, but I do want to take one last opportunity to ask Jeremy a quick follow-up question that came in from one of the public audience members regarding the interventions in New York State. If the main difference, at least in the qualitative work you've done, if what people are describing as the main impact is education, why is that so expensive? Where does the expense come in terms of that?
Yeah, that's an excellent question. The expense comes in developing meaningful education programs, right? And refining them, the time it takes to train the trainers, right? That itself, and then part and parcel to the education is what are you teaching them, right? You're teaching them to adopt specific protocols for recognition and treatment, which is also expensive. So I think, although I would say that respondents in New York really emphasize the value and role of that, they also emphasize that it's this entire picture, right? And I think it really does underscore the issues that Hallie and Vinny just brought up about provider engagement and patient engagement and family engagement, because I really do believe that sort of a rising tide lifts all boats. And I never really learn something until I teach it. And what better person to teach about sepsis than the patient member right in front of me? So telling clinicians that we need to do a better job at patient engagement is actually going to make the clinicians more cognizant of this issue. And unfortunately, all of that does take time and money, but for the most part, it appears to be well worth it and potentially beneficial.
I think, Jeremy, you just wrapped up our session perfectly. So thank you for that. And a very, very big thanks to Vinny and Hallie and Jeremy and Kathy for, I think, what was a terrific session, and I think hopefully very provocative to folks out there as we move along towards improving sepsis diagnosis. Thanks again.
Thanks for having us.
Thank you.